Hello everyone, and welcome to our webinar entitled Sequential Stool Testing to Monitor Progress in People with Rheumatoid Arthritis. Our guest speaker today is Dr. Susan Blum. My name is Michael Chapman, and I'm a medical education specialist at Genova's Asheville branch, and I'm going to serve as the moderator for today's webinar. We would like to welcome Dr. Susan Blum. Dr. Blum is a true pioneer in functional medicine. Dr. Blum is a nationally recognized clinician, speaker, author, and teacher. As the founder and director of Blum Center for Health, and through her education, writing, research, and medical mentorship program, she is revolutionizing the healthcare industry and the lives of those with chronic illness. One of the most common questions we get asked during the webinars is about the availability of this presentation in the slide deck. These materials will be available on our website within a week of the webinar. If you're interested in having these resources, please click the Clinicians tab on the home page where you will find access to our webinars under Medical Education. Or you can also log into your MyGDX account to find these webinars. If you do not have a MyGDX account, please click on the Getting Started link on our home page. And now I'm going to turn the controls over to you, Dr. Blum.
Right. Well, hi, everybody. Happy to be here and to talk about the gut and using stool testing, which I think I probably do a stool test on every patient that comes in here. There's a minority of people who don't get one. And I've been doing this for, a long time, probably 15. Well, I started training in functional medicine in 2001, so I probably sent my first stool test back in 2001. And actually, the stool tests have definitely changed over the years, and I think what I get out of them has also changed over the years, and maybe why I use them and how I use them. So my goal today was really to, when the folks at Genova asked me if I wanted to give a webinar on using stool testing, yes, I happily agreed because I do use stool testing a lot, and I am an expert in autoimmune disease and all sorts of inflammatory systemic illness, and for that reason, I believe stool testing is really, really helpful, and so I thought I would speak on that topic. I did write the Immune System Recovery Plan, which is a book really looking at autoimmune disease, and I have a book coming out it's actually sent the manuscript in this week, and it'll be out in the fall on arthritis, and so I've got my head swimming with all the connection between arthritis and the gut and systemic inflammation, and so that's all in my head, so I thought it would be a good time to give a talk on this topic. So let's see. So we're going to save all the questions to the end, as we always do, and that way they can compile them, and sort of we'll get to the ones that are the most common, questions that everybody has. So if you have any questions as I'm going, I promise we'll have time at the end, and just jot it down so you don't forget it, or submit it, and we'll get back to it. So the first thing I thought we would talk about today is just as we enter into how to use a stool test, I think it's important to understand sort of the role of the gut bacteria, the role of the microbes in your gut in triggering or in maintaining health, or disturbing the environment in a way that leads to a leaky gut, which then leads to inflammatory arthritis. And inflammation, systemic inflammation throughout the body. And so that whole connection, which probably if you're on this webinar, that's not new news for you. And I'm not going to spend a lot of time talking about that, but if you have more questions on that, you can ask it at the end, because I think it's almost dogma at this point that we know that leaky gut increases systemic inflammation and autoimmunity, and so we're going to talk about that connection a little bit and how to use a stool test to understand how to treat that, right? Because I have to say that one of the things I'm the most proud of is, as everybody's talking and, even conventionally speaking about SIBO and other gut disorders, as well as the mainstream understanding now that leaky gut does trigger systemic inflammation or is associated with. Maybe there's a discussion about, does it really cause it, or is it a reflection of what's happening in the body, or is it secondary? Either way, we need to treat it. And so what tools do we have? And I'm so proud that in functional medicine and naturopathic medicine, even before functional medicine came along 20 years ago, was doing this, healing the gut. And we're really good at that. And we're really the leading specialists in this field for treating and repairing the gut, which is now mainstream as we understand that dysbiosis, I mean, look at the whole advent and the research now being done on fecal transplant, and even that's become a mainstream discussion. And so we're good at this. And so so many of you probably are familiar with repairing the gut, and I'm going to share with you the way I do it, and how I use Stool Test to do it. So that connection is well known. So we're going to talk about that. And I'm going to share with you one of my patients. Actually, there'll be a second patient assuming we have time, and how I worked with her. And she's an RA patient. And actually, it just reminded me that I probably should put a timer on, since I can't really, now that I'm full screen, but I can't really see it. So I'm going to do that right now. Okay. So the first part of so we begin with dysbiosis. And for those of you who don't know what it is, dysbiosis is an imbalance in the microbes of your gut. And it can be not enough of the good stuff, or it can be an overgrowth of something that we call bad stuff, right? Simple, but harmful microbes. It could be too much of a good thing, which is sort of what we think SIBO is, small intestinal bacterial overgrowth. It can be an overgrowth of what are inflammatory microbes, what we call harmful, the weeds in the garden, so to speak. I always use, for lay people, I always use, the analogy of the garden and your inner garden, and to have beautiful flowers in your inner garden, which are the good bacteria, you want to have healthy soil, which that's a very important piece, the food you eat, how do you create the terrain that helps you grow good stuff, but, you want to have good stuff, and then you want to get rid of the bad stuff, which include things like yeast, like Candida. It includes parasites, and it includes the overgrowth of harmful bacteria. And when you have dysbiosis, and there's an increased likelihood you will have a leaky gut. I mean, dysbiosis is a cause of leaky gut. And the connection between dysbiosis is now really well studied in the literature, especially for conditions like rheumatoid arthritis and other ankylosing spondylitis, psoriatic arthritis, which are the spondyloarthritises, which also have a connection with a leaky gut, as well as the rheumatologic diseases like the systemic autoimmune diseases like Sjogren's and lupus. And the arthritis can be a component of those conditions as well. And that's under the whole category of inflammatory arthritis. And when you see inflammatory arthritis, you have to think about the gut, and you need to repair it, which means treating dysbiosis, which will be one of the main ways you're going to treat a leaky gut. Okay, so let's first circle back to what does a healthy gut microbiome do for you, right? So in order to understand what dysbiosis is doing, what does it mean to have a healthy gut microbiome? And the word microbiome refers to the whole sort of genetic and, biological bacteria, that are in your gut, although they refer to bacteria in general. I often just switch that to gut bacteria, so right here we're talking about the gut bacteria, and it's sort of interchangeable for these purposes with gut microbiome. Gut bacteria, what do they do? What do they do for you? Number one, they help you metabolize your food. And they help you, I didn't put it on here, but they help you make vitamins. But one of the most important things for our purposes here, and for maintaining a good a good intestinal lining, is they ferment the fiber in your diet, and they make short-chain fatty acids. They make butyrate, propionate, and acetate are the main three that they make. Now, many studies on butyrate and all the good things it does. And actually, while I was researching the book, I thought it was so fascinating that I discovered that butyrate not only works in the local gut environment, but butyrate actually influences your lymphoid tissue throughout your entire body, in your lymph nodes, in your spleen, and it actually increases the functioning, the number and the functioning ability of your Treg cells throughout your body, not just locally. So butyrate does do it locally as well as the other short-chain fatty acids. They help increase the tight junction strength, right? They repair tight junctions. They keep them, they prevent leaky gut, and they treat leaky gut. And they feed the good bacteria, and they feed the cells that line your gut. They help you make mucus, the mucus layer, which is part of your which is part of really important protection. Your intestinal lining, it's all part of your intestinal lining to prevent the leaky gut. It does a lot of other things too. So the fermentation of the fiber by the good bacteria, actually a lot of bacteria ferment fiber. It's not just bifidus and lactobacillus. It's actually other bacteria too, like Bacteroides, make short-chain fatty acids. So there's a lot of bacteria that do that. So we want, and you'll make more of those good bacteria. They'll be healthier and happier and then more abundant the more you eat foods that will increase your short-chain fatty acids. So that's the connection between the food really and the gut, which the single most important factor that drives your what determines the health and the kinds of bacteria you'll have in your gut is definitely food. People with a lot, I won't say the word healthy because everyone has a different definition of what healthy is, but people who are more vegetarian based or have a lot of fiber and vegetable food and less animal tend to have a lot of short-chain fatty acids, and they have one pattern in their gut, whereas people, which is a lower inflammatory pattern, and people who eat mostly animal, and these are, it's not so much about eating paleo, because there are plenty of great paleo people who 10-20% of their food is animal and the rest of it's vegetable, but which is still good for your gut. But people who eat a standard American diet that's mostly animal, dairy, animal products, they have a completely different gut microbiome. And actually, studies have shown that if you swap the diet within 24 hours, the people eating animal food and give them vegetable food, vegetarian-based, in 24 hours their gut changes. So we really can change the gut with our change in diet. It's very, very cool and very important. So the healthy gut bacteria, microbiome, protects and maintains the barrier. Local immune effects. So they talk to your immune system. The DNA of the bacteria themselves, not even just what they secrete, but your immune system, which lays right below the surface of your gut, detects the actual DNA of the bacteria and interacts with the bacteria cell surface proteins, and they help promote the increase of T regulator cells. And studies have shown that when you give somebody probiotics, you increase the functioning of their Tregs, which is the main thing that's going awry in autoimmune disease. So for autoimmunity, the main goal for just generally speaking, and this is sort of a very quick swath on that, but for the immune system, to balance part of your goals, I won't say it's the main goal because there's several of them, but for immune function and your T cells, you want to improve the functioning of your Tregs, and probiotics do that. So the gut bacteria are main drivers for the functioning of your Tregs, not just in your gut, but systemically. So dysbiosis represents an altered state of this gut bacteria. You don't have enough, you're not doing all those things. You don't have enough short-chain fatty acids. You're not protecting your barrier. Your immune system is becoming dysfunctional. And you end up with this increased intestinal permeability, and the leaky gut drives systemic inflammation. And it turns out, like cell walls of gut bacteria translate across the gut barrier and travel around the body, and we've seen immune complexes and gut and cell walls of gut bacteria in the joints of people with RA. I always want to mention a little bit about oxidative stress, just when it comes to rheumatoid arthritis. There's other stuff going on in the joints. It's not just about the gut, right? So you also have to tend to the oxidative stress. And what that means is there's a lot of free radical activity at the joint surface, and you have to tend to that. And in order to quench, this is another gut connection for you, is that you have to make sure the person's digesting and absorbing all their nutrients and getting enough antioxidants into their body, because poor absorption of nutrients will definitely decrease antioxidants. And also, if you have terrible dysbiosis in your gut, you're going to be using up a lot of your antioxidants for all of that sort of repair work and for the inflammation and free radicals you're making just in your gut. And so the importance of enough antioxidants and nutrition status in people with arthritis. So what do we know about the triggers for rheumatoid arthritis? There's a lot of studies. So I put up a few studies here, just what we know about specific bacteria. Proteus has been studied for a long time. And the nice thing about this study that I put up here is, this is post-urine, they found proteus either in the urine or in the gut could trigger RA in some people. And I love this study because this supports our desire to treat dysbiosis. I was looking for a lot of studies to support the approach that if we treat dysbiosis, you can treat the arthritis. And so the studies on Proteus are really fascinating because they've shown that you can actually, by treating Proteus with herbs, this study was using herbs, they showed lower antibodies against Proteus, which corresponded with improvement in symptoms. And so treating the gut with herbs can lower anti-Proteus antibody levels, and that corresponded with improved symptoms. So we definitely want to treat the gut with herbs, which is what I'm going to come around to and I'm going to show you. Now, many studies linking dysbiosis to RA. Prevotella has been studied many times, and there are DNA stool tests of which I'll show you. You can see the Prevotella levels on the GIFX test that Genova does. The problem is that just general Prevotella doesn't subspecies to copri specifically, but this is a specific one that has been associated with RA. But the take home on this is the studies are just looking at all different kinds of dysbiosis. Sometimes they're high in Bacteroides, sometimes high in Prevotella. Sometimes they're growing out in culture, which I see a lot, the Klebsiella, Pseudomonas, those sort of Enterobacter, which you can see in the cultures on a stool test, and you see these inflammatory bacteria. And so these have there are studies linking these kinds of findings, and I think the take home isn't, oh my goodness, I'm looking for a specific bacteria to see if this person has a gut problem to treat their RA. The take home is the dysbiosis is pretty conclusively linked to RA, and you just need to treat the gut with broad spectrum herbs and try to reboot the bacteria. Treat broad spectrum. It'll treat the Prevotella. It'll treat and lower Bacteroides and it'll treat the Enterobacter, Klebsiella, and you just want to treat all of these bacteria with broad spectrum and not go after one specific bacteria. And so, let's see, I think I said most of this already. Best not to focus on the exact strain because we don't really know which dysbiosis is associated with which disease, so good to just focus on treating broad spectrum. And one of the things I love about berberine is that, and I didn't know this until I just finished my book on arthritis, and I was researching everything about berberine, is that berberine actually spares healthy flora and goes after just the harmful microbes, and I love that. I mean, I always thought that you were really decimating, like antibiotics decimate your whole, they sort of napalm your whole gut. Herbs like berberine do not do that. They actually are selective in what they kill. Oh, and actually I forgot to mention, and maybe this is on another slide as I'm thinking about this, short-chain fatty acids, one of the other things it does, they're acid, right? They lower the pH in the gut, and the harmful microbes are actually die in an acid environment. And so short-chain fatty acids actually will help kill off the bad stuff while promoting the health of the good stuff. And so that's another really important function of having good short-chain fatty acids. And another reason why low stomach acid and hypochlorhydria promotes dysbiosis, right? Because you need a low pH coming out of the stomach to kill off the bad stuff, and the good bacteria are actually very acid tolerant. All right, and don't forget about candida, and I'll show you how I did that because a lot of my people end up with having some candida in there, and I don't know if that's because of all the treatment they've had before they can see me or whatever reason. All right, so what kind of information do I need then? So let's all agree we're going to treat the gut, and I think I've made that a very persuasive argument for you. And so what kind of information do I want to help guide my gut treatment? And so this is what I want to know. I want to know if there's candida in there because I end up using specific anti-fungal treatments for candida. Sometimes I use nystatin, and I really love diflucan if it's sensitive to I choose the difference between that. Usually, if for some reason if they're on medication that's already being metabolized through their liver, I might opt for nystatin. Somebody who I don't want to stress the system, diflucan can sometimes cause liver irritation, I say it that way. It can cause increase in LFTs, but I've never seen it happen. But I do have to say it, it's reported in the literature, so you have to warn your patients. So sometimes I stick with that, and sometimes I stick with herbs like oregano. So it's sort of up to you, but I want to hold in my head that I'm working on Candida, because I'll adjust my treatment plan a little bit, and you all might have a different way or your own Candida program that you use, and then you would know to use it, right? So I decide if I'm going to treat for Candida from the stool test. I always want to know if there's parasites there, and I also want to know if there's inflammatory. Oh, that should have been on 2 lines, but okay, it's all right. Sorry. Parasites, number 1. And number 2, and then after that, inflammatory bacteria. And so the ones that grow out in culture, those 4 are the most common ones I see in the stool test that I see associated with an inflammatory, that I see all the time within my inflammatory people. And the anaerobes, you can't really see it. They won't grow out in culture, but if you're doing a GIFX, which is the PCR for the DNA, you can actually get a sense of the anaerobes that are there. And there's other ways to deduce about the anaerobes, which I'll share with you as we go through the stool testing. And so sometimes that, and Prevotella is in the species Bacteroidetes, is in the phylum. It's the bigger category. So you'll see if you have really high amounts of Bacteroides, because it seems that when I see that, and I'll talk about that more in the stool test, but yes, you'll see an imbalance perhaps in the PCR, and I'll show you that later. If there's SIBO present, I think that also drives treatment for me. I find that people with SIBO need 2 months of herbs to begin with, and actually for my RA patients, I do start with 2 months anyway, so it doesn't really change that much. But it might change my treatment just a little, and I might then add a SIBO test, onto the program just to get a sense. But there's signs you can see in the stool test that will suggest that they have SIBO, and sometimes I'll use rifaximin in that case, and I will prescribe it if it looks like there's SIBO present. So I want to know, and then all these things you can follow with sequential testing to see if you're finished with the treatment, and we'll talk about that too. When to know you're done. And then, of course, you want to see if they're just really low in all the good stuff. And sometimes you see that in people who have had a lot of antibiotics and their flora is just decimated. And in somebody like that, you might not need to do herbs. And you might want to just go with a lot of probiotics and a lot of prebiotics and a lot of healthy food, and you approach that differently. So you sort of want to know if you need, how you need to treat them. And that's why I really love having the information from the stool test. Now, specifically on the stool test, the things that I'm looking at are, and don't worry, we're going to get into looking at the stool test in a few minutes, but I wanted to sort of tee it up by saying that these are the metabolic markers that I look at to see what's going on. Now, one of the first things to look at is fecal fat, and you can get that on all stool tests. You can get that on the CDSA, you can get that on the GIFX. You have to ask for fecal fat as an add-on for the CDSA 2.0. You won't get that every time. And the reason why I really, automatically, so you have to ask for that. The reason why I love getting fecal fat is because we have found here, and I've probably done thousands of stool tests over these years, and there's a whole bunch. I have 4 other clinicians working here now, Blum Center for Health, and we all do a lot of stool testing, so we've had a lot, and we have medical meetings every week, and we share our information. So we actually really have looked at this and compared notes, and we have consistently found that people with high fecal fat are likely to have SIBO because they're malabsorbing fat, and you can look at why they have high fecal fat. It's either because they're not digesting fat, and then their triglycerides will be high in the stool, but all the other gut marker, the fat markers, are all from malabsorption. And if they're malabsorbing fat, it usually means that in the small bowel, there's something that's preventing them from absorbing it. And in our experience, it's really associated with SIBO. Sometimes it's severe dysbiosis, and the SIBO piece is not, the SIBO tests are negative, but most of the time it's SIBO. And I really like to follow, when I pick up high fecal fat at the beginning of the treatment, when I start working with someone, I actually am following this to see this resolve before I feel we're done. And so I think it's a really helpful marker. The short-chain fatty acids, I think, are very important, of course, and they're a referendum not just on the bacteria in there, they're a referendum on the diet. And the need to, if they're really low, the microbiome isn't robust, and they're not, you're not feeding the bacteria to make what they need, and that's going to really have a negative effect on your leaky gut and on your immune system. And so we have to get the short-chain fatty acids up. And so we're going to work on that as well. And of course, there's always questions, well, what if you have SIBO and you can't take prebiotics? And what about paleo people who are eating, or the people that eat no grains? And, I would say that the priority for me in working with arthritis, and let's just focus on that, is to feed people prebiotic foods that will increase short-chain fatty acids. And so that becomes a priority for me on the occasions when people have a little SIBO, or they have SIBO, and most, I would say it's not a majority at all. It's a minority of my RA people have showed up also with SIBO. And I just use a FODMAP diet or restrict the prebiotic stuff at the beginning to help them control their symptoms if they're very symptomatic. Otherwise, I allow, prebiotic food in their diet. Beta-glucuronidase is a really interesting metabolic marker, and I think it's for me, I actually really pay attention to this. I think it's an enzyme that's produced by anaerobes that can be really harmful, and of course, it's bad. Beta-glucuronidase will cause you to recycle your estrogen, to reabsorb it, and so it's not good, especially for breast cancer prevention. And so you want to get it down, not only because it's good for your hormones and for preventing too much estrogen activity in the body, but you want to get it down because it's a sign that you have this anaerobic overgrowth that you don't want. And so when there's a high beta-glucuronidase, I actually continue treatment until it's down. And so that is one other thing I'm following, as just an indication that the microbiome is not in good shape, or that there's something that needs treatment. So calprotectin is sort of a derivative of your white blood cells. And so as such, it's really just a marker for immune system activity. It's if you're having some immune reaction in the gut. And so certainly this will help you screen for ulcerative colitis, inflammatory bowel disease, whether or not somebody has active proctitis or diverticulitis, all the itises you will pick up. The other thing that you can pick up is subclinical. If it's a little high, you can say, there's some inflammation in there. And sometimes you'll see it high if there's a parasite. But it is something you want to follow. And if somebody has calprotectin over 50, or is really high, then you really have to be concerned about, inflammatory bowel disease, and if it stays high, and or colon cancer. And so it's actually a really good marker to follow that and to make sure it goes down. And sometimes I refer somebody and I tell them you need to go get a colonoscopy because your calprotectin is high. And so that's really important. And I actually do a feel also, I didn't put that on here, but a stool test picks up blood in the stool as well. And I do want to give you an anecdotal case that we had here. And it was somebody that came in for not an RA, but one of my other clinicians here did a stool test, and she had some blood in her stool. And so the doc sent her for a colonoscopy, and they actually found a pre-malignant polyp in her stool, in her gut. And the gastroenterologist called here and said, what did you do? How did you know to send her? If this had been left in another year even, and she was at 30s, she was young, or 40, it was definitely maybe 40s, but it was before. If she had waited for her colonoscopy at 50, was what the doc said to us, this would have been like stage 3 colon cancer. And as such, we caught it, and the whole thing was taken out. She didn't need anything else other than, excision and biopsy. And so calprotectin is a really great thing as a screening tool, for your patients. So it's sort of a great thing to have, to know from a prevention standpoint. And also, if it's high, though, you want to follow it and you want to follow up on it. And so EPX, for me, when I see a high EPX, I start looking for parasites even harder, and I do have a local guy in New York City. Sometimes stool tests aren't really the best at finding a parasite because, the parasites often have to be excreted in the stool to pick it up, and it's not a fault of the stool test per se. It's really just the way it is with parasites. So if the EPX is high, I continue to look harder, for a parasite. I send them to the parasite guy in the city who does a scraping of the distal sort of proctitis, the area, sorry, some of the distal colon, really, the end. And he can get in, he does an anoscope, and he scrapes, and he can look. And eosinophils is what the EPX is showing you is an allergy marker, and that's the bottom line. And I'll send people to the allergist to look at actual true food allergy testing to see whether or not if the EPX doesn't go down. But I find that the eosinophils are really reacting to not just run-of-the-mill dysbiosis. Sometimes I see it can be up if you have candida, and I didn't put that here, but parasites, candida, food allergies, you have to sort of know to look for other things with that. So all those things are really important, and we want to know about them. And what can you do if you don't want to? What does conventional medicine offer us? For that, the first thing is about the calprotectin, and the calprotectin, because it's become a mainstream test, and the studies show that it's such a good screening test. You can actually get stool for calprotectin through a conventional lab. And you can actually get fecal fat also through a conventional lab. The problem is they're not as sensitive. They're not, the ranges are not necessarily that helpful. They're not as standardized for what we're looking for, but it is possible to get it. So, but you can conventionally get it covered by insurance and have the breath testing done by your gastroenterologist. You can send out stool for ovarian parasites. I've never found anybody come back with anything positive from that. Now, at the end of the day, your patients might end up going and getting a endoscopy or colonoscopy. That's really the tools that the what could the gastroenterologist really do for your patients? They can do an endoscopy and look in and see if it looks like they're having reflux, or if they're having gastritis, but all that tells you, if they have reflux or any of those things, it tells you they probably have dysbiosis that you need to treat, and or they have just a food sensitivity that needs to be treated, and so in terms of reflux, but it means they need some sort of treatment. And I also didn't mention then about the digestion markers, and whether they're not digesting their food, which could be a problem in reflux. So endoscopy will help with that, and I have to say that I find endoscopy and colonoscopy, like I said, there's a reason for using those things in addition. Those are not separate. They're not going to replace using a stool test to follow dysbiosis. None of these things are really going to help you identify, treat, and follow bacterial or yeast dysbiosis in your gut. And so what kind of stool tests do we use? Now, the two tests that I use commonly here, and sometimes I'll just use a basic CDSA if I'm just doing a quick follow-up for the cultures, like want to see if the candida's gone, I'll just use the CDSA. But the GIFX or the CDSA, now, until recently, we really couldn't do a GIFX with our Medicare patients, and so you're going to see the case study that I'm using today. The main one is going to have used the CDSA. And then the second one I put up with GIFX, and so that we can at least talk that through. I always use it for my initial assessment, and then I follow it. And because here's the thing, and this is something that I have come to learn, and this is my sort of 15 years of functional medicine experience, is that one of the things that I think we fail to do in the whole integrative medicine sphere is that we don't finish what we start. We don't, we all know the 5R gut program from functional medicine, and we know how to sort of do this program, and we can get people started. Here's your 30-day gut program. Here's how to reboot the gut. That's not enough. And actually, somebody with RA or somebody with inflammatory arthritis, you're going to be working with them for a couple of years. Although I have to tell you, I had the second case today is somebody who had early inflammatory arthritis, and it just happened, and we were able to treat him quickly. But somebody showing up, or somebody that has a diagnosis, is on multiple medications, that's going to take you a while to get ahead of that. And you have to finish what you start, and which means multiple courses of gut treatment. How do you know what to change to? How do you know if you need to keep going? And that's finishing what you start is really what I'm all about these days, because I have so many people in my practice that I've been following for a lot of years, and this is sort of my take home and my sort of clinical pro I want to share with you, is that it's not enough to just feed their gut once. I mean, it's sort of like detox. Somebody who's a big toxin load, you can't just do 21-day detox and think you're done. That's not going to really unload their toxic burden. You have to look at, how are we going to finish this? How are we going to continue it? And how are we going to finish what we start? So let me tell you about my patient Jean. Now, she is the most wonderful woman, and well, of course, most of my patients are, I like to think, but but the nice thing about June is she came religiously, like every 4 to 6 months she came back. We worked together for, 2 years. She came in, she had RA for 2 years at the point that I first saw her, and she developed RA really quickly. I mean, within 2 years, so she came to see me, she was 2 years in. Within 2 years, her hands were deformed, she had terrible pain, and she really was anxious. She had tried everything else, right? She was on Plaquenil, methotrexate, prednisone. She tried other things. The prednisone, none of those things worked. They finally added prednisone, and she was on 5 milligrams of prednisone that she couldn't get lower when she came to see me. Even with all that on board, she could not open water bottles. Her husband was clasping her bra and getting her dressed in the morning. She was really, really disabled. And she had a very interesting history, and the history, right, timelines. It's so important that we all get the history of our people, and it was so clear to me. Sometimes it's very obvious that there are gut issues, and sometimes it's not, but with her, it was really obvious. Her husband worked for the government in the Foreign Service, and so she lived abroad most of her life and had only moved back to Connecticut like 5 years prior. Actually, the RA developed after she moved back to the States. But she had a history of parasites, giardia, worms, dysentery, colitis. She had so many gut issues. When she came to see me, she actually had like no gut symptoms, very much. I mean, mild, if anything. She had none of these things, and they were treated multiple times in the past. When I did her initial testing, she had positive CCP antibodies. Now, for those of you not familiar with RA, there are 2 antibodies that we test for. One is rheumatoid factor and one is CCP. CCP antibodies, when they're positive, are the most conclusively associated with RA. They are, whereas a rheumatoid factor can be false positive from infections mostly and other autoimmune conditions. You can actually get a positive rheumatoid factor after a viral illness. There are certain things that can trigger RF. But CCP, if it's positive, they have RA, and it's called it's a citrullonated peptide antibody, and this whole thing about citrullination of peptides we won't talk about today, but just that's what I was following, is what I want you to know. I was following her CCP then to see how she was doing with the treatment. Her CRP and the ESR, those are inflammatory markers. With the treatment that she was having with the Plaquenil, methotrexate, and prednisone, her CRP and her set rate were fine. Okay, they were really not bad at all. But she was still very symptomatic. Her ANA was negative, her vitamin D seemed okay, and the chronic pain had just depleted her adrenal hormone, the DHEA, was depleted. And so the take home I just want you to get from this is that medication can appear to be helping, but people can be really symptomatic even if they get the inflammatory markers down. And so you have to find what you can follow to see whether or not they're improving. And for her, it was the CCP. Well, the flow in my office is that at the first visit, I send them home with all the stool tests and all the test kits that I'm going to do, and I put them on an elimination, the arthritis diet, which is really an elimination diet and removing nightshade vegetables. And I put her on, and I use a lot of anti-inflammatory protein shakes. I actually really like the new Ultra-Inflamex from Metagenics. I don't know if I'm allowed to say where I got that from, but it's clear Ultra-Inflamex is from Metagenics. But I use like a 369 fish oil, like a tablespoon, get them up to really high doses of, 3 grams of EPA plus CHA and 500 milligrams of GLA. Studies really good for using omegas to help reduce inflammation in arthritis. So I send everyone home with vitamin D, omegas, and then Inflamex shakes. Go on the diet and do all your testing and come back in a month. And when she came back the following month to review her tests with me, she had already dropped her prednisone in half. She had some digestive issues, so she was having some gas and bloating and a little constipation, but and so that all was relieved just from the food plan, right? And from the anti-inflammatory supplements that we started, and her hands felt much better, but not in her knees. And so at this visit, I looked at her stool test. And the other thing about her that's important to know, and this is relevant when it comes in terms of stress, because one of the things I'm going to, a take-home message for June, is that her symptoms ebbed and flowed with, she was a teacher, and it ebbed and flowed with the stress of her school year. And her stool test sort of changed with the school year, right? So, and the need for treatment. And so this test we looked at was done in May at the end of her school year when she was having the most stress. But interestingly, her symptoms did get better already, right? With just the food plan and some basic supplements. And so that's a really important message. You can get really far with the basic, helping cleaning up the food and giving people anti-inflammatories. So when I looked at her stool test, she had candida and high beta-glucuronidase, no growth lactobacillus, and low butyrate, and I'm going to show you that now. But what I was the most impressed with was that the stool test I looked at and I thought, this really isn't as bad as I would think, based upon her symptoms, right, and how bad her rheumatoid arthritis is. And so this is her results, and the cultures are on the next page. So her digestion absorption, it looked like she was making enough, pancreatic enzymes. And digesting her food. Her eosinophils were just a little high, just a little outside the range, 1.2, and I think that was from the candida for her. If it was really high, I would have gone looking for parasites. It didn't show in the stool test. The calprotectin was good. And her short-chain fatty acids, you can see her butyrate was very low. And so her, health of the microbiome, I'm a little concerned from that. And her beta-glucuronidase was very high. So clearly there's some overgrowth of anaerobes. And the bile acids are a referendum on how well, on really the gut bacteria. Because if you have an overgrowth of some of these inflammatory bacteria, they deconjugate the bile acids, and you can see very high levels of one of them and an imbalanced ratio. Her H. pylori was negative, and then her cultures, there it is. Her cultures only showed candida, 1+. Now, and the other thing about her cultures, though, you can see her lactobacillus wasn't growing and bifidus was only 1+. And so clearly, her terrain isn't so good. She's low on the good stuff. And she has 1+ candida, and I do have to say that when I see candida, even 1+, when it looks like it's only, people say, well, it's only 1+, it's not sort of in the high yellow zone. I actually still feel that that's a tip of an iceberg, that you really don't know how bad it is, and often it's much worse than it appears. So I actually do believe in going after candida, even though it's 1+. And I suspect that there sometimes, different balance, sometimes you get sort of more out of a stool test than not, but this is certainly indicated that there's probably anaerobes here that we weren't seeing. And I judge that based on the high beta-glucuronidase. When you do a GIFX, you can see the anaerobes better, but I couldn't at this time do that because she had Medicare, and so I needed to stick with this stool test, and so that's okay, and you just sort of deduce it. If there's not good stuff growing, and I knew she was, and she was eating sort of a standard American diet, so she actually was not eating a lot of prebiotics, so I knew we had some work to do with her, and I definitely put her on a gut cleanse and there's her parasitology. So I sent her home with a month of her. So my standard is sort of herbs and then aromatic herbs. So a month of, at that time I was using a lot of tricycline from ADP, and 2 months 2-BID with 2-BID oregano, and you'll get these slides. So I'm going to just move through these. I want to make sure we have time for questions. Put her on a combination of tricycline and oregano, month 1, and then I gave her nystatin month 2, and kept her on the same program she was on with the Inflamex, the fish oils, and I added glutamine powder, 1 teaspoon twice a day, and I put her on a probiotic, 50 billion, because she was so low in the good stuff. I had her take it at bedtime away from taking the herbs, and I just do that to be safe, because I was giving her a whole range of herbs and not just berberine, and I wanted to make sure we wouldn't kill off the good stuff at the same time she was taking it. She stayed on her arthritis diet. Actually, wait, that's not true. The ones that she needed to stay off of after doing the reintroduction was gluten, dairy, eggs, and nightshade. She stayed off of. And she came back 4 months later, and she was very happy. And don't forget, this is also in the summer, right? And so by the time she came back, this was her, when I say visit 2, this is actually visit 2 of her treatment, right? So this is her third visit with me, actually. But it was already the following spring, in summer, like June. And she was feeling so much better. Oh, actually, I'm sorry. I take it back. That was wrong. This was at the end of the summer, because I saw her in May, and then she came back in June to go over her test, and then I saw her before school started in August. So I saw her like the end of August, and May, June, July, August, September. So sorry, maybe it was September. But I saw her before school started. This was definitely a end of summer visit. And her symptoms were much better. She was very happy. And she was able to open water bottles. I mean, this is just from 2 months of gut treatment and following the food plan and staying on the anti-inflammatories. She was so, so happy. Her knee was better. Her energy was better. She had been taking a lead. She was able to drop on that. And here's what her stool test looked like. And you can see that this time I switched over and I did a basic CDSA. And so I got the fecal fats this time. And her fecal fats were okay, so she wasn't having big malabsorption that I was worried about. So it definitely did not look like a SIBO. Let me just move this away. And so you can see, though, that in her cultures, she showed up with some bacillus and pseudomonas. And so that concerned me, but the yeast was gone. So her yeast was gone. And which was good. So Candida looked like it was gone, but now we have some bacteria we want to treat. Her beta-glucuronidase had dropped a couple of hundred. It didn't drop big, but it definitely dropped a little bit. So I knew we had made progress, and she certainly had felt better. You can see here that she had some blood in her stool. And so I did refer her for a colonoscopy, and she was cleared by her gastroenterologist. So that's always routine for me, how I handle that. The bacillus, that you do get some sensitivity testing for the bacteria, and it's sensitive to herbs. So I decided the beta-glucuronidase was a little bit better. She had Pseudomonas and bacillus. This is just a summary, so you'll have this at home. I just interpreted it already for you, and we saw the test together. This is my interpretation of the test, which I shared already. I sent her to GI, and I continued her treatment, and I switched it up. And so I tend to rotate herbs and I give them different things each time. So this time I sent her home with Candibactin BR, which was 2 twice a day for a month. The yeast was gone, so I didn't add oregano. Oregano is my sort of go-to to add into the program when I see yeast. I gave her Candibactin alone, and I left her and everything else. She came back 4 months later, and this is December now, right? And she is stressed. And work for her is very physically demanding. She has to cut scissors. She works in like second grade or first or second grade with young kids, and she's a special ed teacher, so she does a lot of artwork, and she has to do a lot with her hands. She was so stressed she gave up on her diet, and her symptoms had flared. And for her, that was very common. Her symptoms were always flaring during the school year. When she came in, I did her blood work, and her CCP was high as 82. And this is the first time I actually had done her cardio CRP. I switched over from the other CRP, and I saw that was high. And so these were now the markers we needed to follow. She had come in just to check in and hadn't brought a stool test with her, but because she was having a flare in her symptoms, I sent her home with a different program of herbs. Don't forget, I had only done 1 month back in September, and now this is December, 4 months later, and I said, okay, let's do another month. And so I decided to switch back and give her the double. Again, I added oregano because I don't just do it for yeast, it also enhances the effectiveness, I believe, in just herbs and other herbs, like what I call the green herbs alone. GI Microbex by Designs for Health, which I really love, and oregano, and I gave her a month of both of those together. And then she came back at the end of the school year in May. And again, she had a rough winter. She had the flu and strep during the winter and took antibiotics. And she was definitely not able to stick with the food plan. She was following some of the time, but the good news was she wasn't strict on the elimination diet with the arthritis, nightshade elimination, but she did overall was eating less processed food and sugar. There were things she had kept to her, she had kept. She was still in the, she had hung in there on 2.5, but she didn't want a prednisone. She didn't want to change it. And so, in general, though, she had at least was stable symptom-wise from the initial improvement. You know, she was still able to, like that flare she had in December was gone, and she was stable, so she was back to and stable on being able to do more and dress herself and everything, but she hadn't made any progress. The CDSA that we saw, and I'll just pop it up now, oops, let me go back, was that when I saw her CDSA, I said, okay, well, you know, the candida's gone, and look at the beta-glucuronidase. I mean, it really dropped. I mean, that was great. And her fecal fats were always low. Her butyrate had just come up a teeny bit, not much. Maybe a little not chewing her food, not digesting her food, but she's still not growing great lactobacillus, and she has only this 1+, you know, proteus and no more blood in her stool, and so she looked like she was making a little bit of progress with the stool test. Now, okay. But she had just come and she had the flu. Because she had the flu and the stool test and symptoms were pretty stable, I said to her, you know, your stool test looks pretty good. You know, you had the winter flare, but you're better now. You came out of that. Let's just let it ride. Let's focus on food, mind-body practice. And I gave her just 2 weeks I went back to tricycline again and just to do 1 bottle, 2 weeks, a little bit of a boost to get rid of that last bacteria there. And we'll just leave you alone and give you probiotics and glutamine and work on food and relaxation. She came at the end of the summer with her SIBO test, and I know we're running out of time to get to questions, so I'm going to go quickly. She came, and I had her do a SIBO test, and that ended up fine, actually. And she came back then in the end of the summer, and she did better. I mean, the summer for her is obviously great, right? So she came back at the end of the summer, joint pain, energy, gut, all improved. I redid her blood test, and the CCP was 7.6, and I completely normalized. And I hadn't done it since December when she was in the middle of that flare. And so she managed, so you can see that during that whole 6-month period we did multiple rounds of gut treatment, and then just support with food and relaxation over the summer, she was able to really repair. The CCP came down, and that was definitely consistent with how her everything was normalizing, her stool test and her symptoms. So her SIBO was normal. Now, at that visit at the end of the summer, I will throw in here that she everything was improved, but she was still stuck on 2.5 of prednisone, and she still had, you know, some symptoms. She wasn't 100% no symptoms, but she was very, very happy. But I also then went around and I said, okay, let's take a look at your NutriVal and just see what's going on there. And I do it not only it's sort of the next step for me. It's like, okay, let's see if there's any dysbiosis markers that we're not seeing. And let's also see how your oxidative stress is, and let's see if you need any other nutrients, and moving you towards more sort of bringing this home. You know, I want to now focus on oxidative stress, and if there's anything else we need to do to continue to improve your symptoms. And when I did this dysbiosis markers and I saw that her yeast markers were all high, and she still had a few dysbiosis markers, I thought, you know, we need to treat that. And so I actually, I gave her diflucan. I actually had that on this slide here. I gave her diflucan 100 milligrams for 2 weeks. I added digestive enzymes because her amino acids were low on the NutriVal, which you won't see. And it helps me. NutriVal is a good referendum on whether or not you're digesting your protein. And she also needed a lot of support for oxidative stress, which I thought, and I gave her NAC and lipoic acid. So she came in the middle of the school year for her 6th visit. It was December, and she did not have a flare. It was the first time that she ever didn't have a flare. She was thrilled. She only had a little pain when she overworked her hands. Her blood tests, CCP, were all normal and stayed normal. And she was retiring in 6 months, and she was so excited. And she actually has never had a flare since. Since that flare she had during that first year, we were working together. She made it till her retirement, no flare. And then her follow-up, I didn't put it on here, but her last stool test that we did, her short-chain fatty acids were still a little lower, and so I wanted to focus on repair now, to finish this, to help her gut be healthy. I added enzymes. She was on enzymes. I had her stay on them. We worked on prebiotics, and we worked on just healing her gut at that point. Leaky gut, stay on the glutamine. So gut healing for the next 6 months, no more herbs. I increased her probiotics to 100 billion a day. I read she had prebiotic digestion. She returned at the end of the school year, was really excited. She could open her jars. And she moved her own boxes out of the office. I mean, it was really a great, great story. And she dropped back to 95% nightshade, gluten, and dairy-free. You know, at some point people have to move over to something they can live with. And we made a plan to tapering prednisone. Now, I'm not going to have time to do Robert today, but you have this here. He's just I'm going to just tell you who he is. He is a really wonderful guy I was working on for cholesterol and a high PSA, and he developed inflammation and arthritis in 2 of his fingers or 3 of his fingers while we were together. And so I was able to jump right in, do his stool test, see what was going on. All his testing was negative. It was just an inflammatory arthritis, a pre and early undifferentiated inflammatory arthritis. But his stool test was really no SIBO markers there, but he had a lot of yeast. And look at his dysbiosis markers on Nutrival. And so sometimes you pick things up. The stool tests are not perfect, but they're really helpful. And so there is some imperfection with them. And you can see in the GIFX his Prevotella and Bacteroides was sort of high, especially the Prevotella. But that's not really why I focus on treating his dysbiosis and the yeast, mostly because of these 2 things, which I had both of them to look at. And so I sent him home with a lot of herbs. I gave him a full month of Disulfiram for that 2+ Candida. And I spoke to him on the phone. He hasn't been back with his follow-up stool test yet, but a month of all the herbs and his arthritis was gone. So that was really a very quick, good success story. So take home. Marathon, not a sprint. Finish what you started. Multiple rounds of herbal treatment. You need to know when to stop. I mean, it's okay to let things ride and then do a stool test in 4 to 6 months and see if you have to continue treatment. When I say let it ride, just do healing stuff, probiotics, glutamine, but don't forget to come back and do another stool test and see if you're done, especially if somebody has hit sort of a plateau and they're not getting better. And don't forget to use dysbiosis markers in the urine. I find it really helpful to add information because stool tests are imperfect. They're helpful, but they don't always tell the whole story. And I did it. Okay, that's it. So we got through, but oh my God, it's 1 o'clock. I'm so sorry. I took the whole time.
Thank you, Dr. Blum, for a terrific presentation. And unfortunately, in the interest of time, we're not going to have time for question and answer period. I just wanted to say that for additional educational materials, we'd like to encourage you to visit our website, www.gdx.net. On this site, you'll find sample reports, kit instructions, and other information for all of our profiles. And after taking advantage of these materials found on their website, feel free to contact client services with your questions, and additionally, please call client services if you need assistance in setting up an account. Finally, we'd like to encourage you to look for upcoming webinars on www.gdx.net. Next month, we'll have Michael Chapman, who will be presenting on the lifestyle factor, utilizing testing to encourage behavior change. And thanks again, Dr. Blum.